Hello, friends of the Retina Channel podcast, and welcome to episode 78 of the series. My name is Kayvon Kushan. I'm your host for this podcast, and today I have the pleasure of having Dr. Arthur Sitt as our guest to the show. Dr. Sitt is not a retina specialist, he's a glaucoma specialist who published an interesting article with his group that crosses our fields of retina and glaucoma. And it specifically talks about the effect of the scleral buckle on flow dynamics of the fluids inside the eye. The name of the article is The Effect of the Scleral Buckle Surgery on Tonographic Outflow Facility, Positional Intraocular Pressure, and Ocular Biomechanics. It's an interesting prospective observational case series that interestingly shows us that presence of a scleral buckle somehow reduces chance of glaucoma progression or improves aqueous flow dynamics in the eye to protect against glaucoma. He goes over details of how his group measured these dynamics, and it was very interesting. I learned a lot from this discussion. Dr. Sitt, just to give you guys some background, he's a professor of ophthalmology, research chair, and glaucoma fellowship director to the Department of Ophthalmology at the Mayo Clinic in Rochester, Minnesota. He's actually an engineer, a mechanical engineer from his background from the University of Toronto. He did a master's degree as well in mechanical engineering at MIT. He then did his medical school and residency in ophthalmology at the University of Toronto, where I am. And then he went on to do glaucoma fellowship at University of California, San Diego. And since then, he's been very active in research, and he has contributed a lot to our field. His main research interests are mechanical properties of the eye that control intraocular pressure variations and contribute to glaucoma. And that really includes aqueous humor dynamics and ocular biomechanics, which he goes over details in this article. He was of note of as many achievements he's had of note, some of them just to mention. He was the 2024 American Glaucoma Society lecturer. He's an American Glaucoma Society Clinician Scientist Award. He has won that. He has also been awarded World Glaucoma Association Young Clinician Scientist Award, American Academy of Ophthalmology Achievement and Senior Achievement Award. And he was the program co-chair of the World Glaucoma Congress from 2019 to 2023. I enjoyed talking to Dr. Sitt and during this podcast recording, and I learned from him and from his very in-depth scientific discussion and very, very kind demeanor. So I look forward to present this podcast recording to you as well. Without further ado, this is the conversation. Good afternoon, Dr. Sitt.
Good afternoon. How are you doing?
I'm good. Welcome to Retina Channel podcast.
Yeah, thanks. So, so you're in Toronto, right?
I'm in Toronto. I'm in your hometown. Welcome back.
Yeah, that's great. Yeah.
I already went over your bio with the listeners and viewers. You did your medical school and residency here. Is that correct?
That's right. Yep. So, Toronto is my hometown.
Wonderful. So, welcome back virtually. And I know you're in the Rochester Mayo Clinic right now. So, I'm very happy to meet you, nonetheless, virtually, but hopefully we get to see each other in person very soon.
Yeah,
and
absolutely.
I'm happy that you agreed to come on the podcast to talk about your very interesting article in Ophthalmology Glaucoma on the effect of scleral buckle on IOP and aqueous humor dynamics in the eye.
Mm-hmm.
I was intrigued by your article. Two people actually suggested that to me, and I came across it on the Academy publications as well.
Okay.
Alan Berger, Dr. Berger, who is one of our retina people, suggested that to me. And you did a podcast for the Academy as well on it. So it's a small publication, but I would say it created some noise.
Okay. So I'm always happy when retina specialists take a notice of glaucoma publications. I think that's fantastic.
Of course.
And Alan Berger, he was one of my one of my teachers when I was in Toronto. So it's great to hear that he saw the paper and was intrigued by it.
Absolutely, absolutely. He was. So, Arthur, tell us about the background of this publication. There's
Yeah,
usually a question that the authors want to address, some dilemma they want to sort of solve. What made you and your group to look into this issue?
yeah. So it started off um, with a completely different question. So as a glaucoma specialist, one of the things I truly dislike doing is performing filtering surgeries after scleral buckles.
Yes,
I'm sure you've heard that from your glaucoma colleagues that it's not
absolutely.
it certainly makes things more challenging, and so we have the ability here in Rochester to look at our entire population on something called the Rochester Epidemiology Project, which captures the medical records of everyone who lives in Olmsted County. So we can actually follow their health status over time of the entire population. So we wanted to see if if having a scleral buckle versus having a vitrectomy was better or worse for glaucoma. And of course, there's the work from Stanley Chang, who suggested that vitrectomies could increase um, uh, uh, oxygen-free radicals and potentially cause increase in intraocular pressure in glaucoma. But I would have been very happy from a glaucoma specialist standpoint if that were not the case, and and vitrectomies were better.
Your surgeries would be a bit easier.
Exactly. Yep. So we underwent this project to try to understand, what was the risk of glaucoma after vitrectomy, after vitrectomy with scleral buckle, and then after scleral buckle alone. And we were so we found that vitrectomy did increase the risk of glaucoma compared to the normal population, and that fit with the work from Stanley Chang and others. What really surprised us, though, was that in the patients that we identified who did not already have glaucoma, but then had a scleral buckle, none of them developed glaucoma. And that
Interesting.
really intrigued us. And so we really want to find out why that might be the case. And so that's
Interesting.
that's where we got into the paper that you saw, looking at the
Yes.
effect of scleral buckle on outflow facility and
Yeah.
ocular rigidity.
Yes, wonderful. So you had this idea that the buckle could be protective against
Right.
glaucoma, and so you want to study that in more detail. Um, Wonderful. So this particular study, you had 9 patients who, if I'm mistaken, please correct me, that they had unilateral primary scleral buckle surgery, no vitrectomy for regular tardiness detachment, and you used these 9 patients as their own control using the contralateral eye, and you looked at the change in IOP from the sitting to supine position, and you also calculated the ocular rigidity and flow facility, outflow facility, and you came to some interesting conclusions. So tell us about it, Dr. Sid. So these 9 patients, they're retrospective or they're prospective. Could you tell us how you selected those patients, please?
Sure. So they are they were enrolled after they had their scleral buckle surgery,
Mhm.
but then we prospectively collected their data in terms of IOP, change of IOP with body position, outflow facility using tonography, and then ocular rigidity using the Friedenwald ocular rigidity coefficient, which is actually a pretty old measure of the rigidity of the eye. But
Okay.
a
Okay. So
lot of it's different. Yep.
I hope we can maybe clarify that, or if someone who's not glaucoma maybe could kind of maybe explain that to me. So you measured the change in IOP from sitting to supine. That seems pretty simple to
Yep.
me,
Yep.
and that's pretty much standard tonometry, correct? You measure.
Exactly. Yep. We use a pneumotonometer, which allows us to measure in any body position. And so it's pretty standard technique that we've used in many previous studies to look at difference between sitting and supine pressures.
Gotcha. And that's the pneumotonometer is essentially applanation principles, correct?
Correct. Yeah.
Okay. And then another thing that you the results were quite interesting, that change from sitting to supine was increase in intraocular pressure in the control eye, but less so in the buckled eye, correct?
Exactly. And we've known for a long time that IOP varies with body position. That's very well described, and we know that IOP increases normally when you go from a sitting to a supine position. What we weren't sure is what would happen in the buccal patients, and so we saw that the change in IOP from going to the sitting to the supine position was reduced in the scleral buccal patients.
Mm-hmm. And the change from sitting to supine was quite significant for the non-buckled one.
Yes.
If I'm mistaken, 16 to 21 or so. Let me just go back to your table, if I'm not mistaken. From 16 and seated to supine, which is 18.7. So from 16.7 to 21.3 for non-buckled,
Right.
and 16.1 to 18.17 to increase, but much, much less in the buckled
Yes.
eye. So I learned
Exactly.
two things here. One is the result of your study, which says buckled kind of protecting against increase in IOP. The other thing was that non-buckled eye had significant increase in IOP
Yep.
from just supine, I guess, let alone yoga positions, things like that.
Exactly. Yeah. So um, that's normal. That happens. The magnitude of the ILP change from sitting to supine varies depending on populations, but having a 3 to 5 or even greater ILP millimeter of mercury change from in between those body positions is very normal, and then it tends to be increased when you get into glaucoma patients.
Wow, that in glaucoma patient, this change is even more magnified. Okay.
Exactly. Yep.
Um, so the other two variables or so outcome measures that you had was the outflow facility and ocular rigidity. And
Right.
those are the more sort of finicky things for a retina person like I am.
Yep.
So could you clarify what you mean by outflow facility?
Sure. So outflow facility is essentially the inverse of fluid flow resistance. So if you think about how easy it is for aqueous humor to drain from the eye, there's going to be a number of parameters that determine that. One is your IOP.
Mm-hmm.
The second is the back pressure, which
Mm-hmm.
is the episclerovenous pressure. And the third main thing is the resistance to flow, which is primarily in the trabecular meshwork, and then in the distal episcleral plexus.
Mm-hmm.
So when we measure that resistance, we actually measure the inverse. So we measure the outflow facility, so how easy it is for fluid to drain out, instead of how difficult it is for fluid to drain out from the eye. And
Mm-hmm.
the way that we do that is we have the tonometer, the pneumotonometer, and we place a weight on the eye. So it's a 10 gram weight on the eye. And so you can imagine if you place a weight on the eye, that's going to cause an increase in intraocular pressure.
Yes.
And then over time, that pressure is going to slowly decay down back towards its baseline. How fast that decay happens is what allows us to calculate outflow facility.
Okay. So essentially, you're it's a reverse of resistance in a way.
Exactly. It's a reverse of a
Reverse.
resistance. So we're
Okay.
increasing the pressure. So if you have high resistance, that pressure is going to stay elevated for a longer period of time. But if you
Mm-hmm.
have low resistance or high facility, and then that pressure is going to drop back down to baseline more quickly.
Okay. So you're creating some energy for the eye to work with, and you're measuring the resistance by looking at the normalization of the pressure.
Right? The speed at
Okay.
which it
Oh,
normalizes.
okay. To speed. Okay. Now again, in a way, is like electricity. Uh,
Yeah, yeah. So the mathematics for fluid flow is exactly the same as the mathematics for electric circuits. So
yes.
so, so yeah.
Okay.
So we have so if you understand electric circuits, so pressure is the same as voltage, and current is current,
Yes.
and current is fluid flow, and then resistance is resistance.
Okay. Okay. So your pressure is what you know is 10 grams, and then um, I guess what and your So I'm getting it now. I think I'm getting it. So yeah. So you have a known pressure difference, which is the 10 gram, and then through which you get your resistance or outflow facility.
Right. So the 10-gram weight, it doesn't give us a known pressure change, but it gives us a measurable pressure change. So, it's just like pushing on your eye. It's going to cause the pressure to go up. And we can measure what that is, and then we can measure how fast it decays down.
Gotcha. And so this procedure, you do that in, again, seated and supine.
No, so this is only performed in the supine position because
Only
we are
supine.
putting on a weight on the eye, so it does depend on gravity pushing down on the eye.
Yes, makes sense. Okay, only in supine. Okay, and when you did this, you compared again buckled and non-buckled eyes, and then it wasn't much different, correct?
Correct. Yes, and so that was something that we weren't sure what we're going to find. It does help to validate some of the things that we talked about, because one of the things, so other than ocular rigidity, which I'm sure we'll get to,
yes,
the other parameter that can reduce pressure fluctuations in the eye is outflow facility. So again, if you have very low resistance or high outflow facility in the eye, if you push on the eye, the pressure comes back down quickly. So that's reducing fluctuations. And so if you had increased outflow facility, then you can have less of the fluctuations in pressure, so less of a change from sitting to supine, without having change in rigidity. So since we didn't find a difference in facility, so we knew that wasn't contributing to the differences in ILP that we were seeing between the two groups.
Gotcha. And maybe unrelated to this particular article, but I assume in a glaucoma patient, you have reduced outflow facility. Is that correct?
Generally, exactly. Yeah. Okay. And that's because of disease in the trabecular meshwork.
Gotcha. Okay. And then the last thing you mentioned, the ocular rigidity. And the ocular rigidity. So let's explain that. What is that? What do you mean by ocular rigidity?
Yep, absolutely. So, if you think of a balloon, the way that you inflate the balloon is you apply pressure, you blow into a balloon, and then when the pressure increases, the volume increases as well. And then if the pressure decreases, the volume decreases. So how much that volume increases, so if you have a really stretchy balloon, then if you have a little bit of a volume increase, a little bit of a pressure increase, the volume will increase a lot. But if you have a really stiff balloon, you can really blow on it really hard, but the volume is going to increase very little. So that property is it's the compliance, but really it's the same as the rigidity. So if you have a very rigid balloon, you can add a lot of pressure, but the volume's not going to change much. But if you have very low rigidity, you can add a little pressure and the volume will change a lot. So it tells us about the properties of the tissues of the eye, in particular, probably mainly the sclera is contributing to that property, since most of the eye wall is consisting of the sclera.
How malleable it is, how expansive.
Exactly. Exactly.
Okay. So that's the ocular rigidity, and you have a way of measuring this as well. How did you measure that?
Yeah. So this again it's actually part of the tonography measurement where we measure outflow facility. So if we have our patient lying down, we can measure the pressure in their eye. I'm using the pneumotonometer, and then we can measure the pressure in the eye after we place the weight on the eye. So that same 10-gram weight is going to increase the pressure. So the difference in pressure between having no weight and having the 10-gram weight gives us a specific pressure change. And then and then there's some old work looking at the geometric changes in the eye depending on how much pressure change there is, and so you can calculate the volume change before a given pressure change. So if you know the volume change for a given pressure change, then you can then calculate the ocular rigidity.
Gotcha. And how do you measure the volume change? Like,
Yeah, so the volume change. So that's a great question. So in our study, we used some tables that were developed several decades ago that were specifically for the pneumotonometer. If you can also measure it with OCT, other investigators have done that. So if you want to get a little bit more nuanced, you can definitely do that. What we were more interested in is, is there a difference? And so for us, using the tables was a good enough approximation.
Okay, so it's approximately based on change in pressure, how much volume change probably is around. Is that correct?
I'm sorry, could you repeat
Based
that?
on the IOP change, those okay, so tables correlate the change in volume to change in IOP. Is that correct?
Exactly. Yep.
Okay.
Yep.
Okay. Well, and so I feel there's a lot of physics here. So a lot of yeah.
Yeah.
That's good. Okay.
Yeah. So I'm an engineer by background. So
Yes.
that's why I have an interest in this area.
Yes. It totally shows. It's wonderful. Yes. I liked physics. When I was in high school, I loved physics. I guess I can
Great.
relate to that. Although I've forgotten a lot of it, but that this work sits with me.
Great.
So you showed the ocular rigidity was actually decreased in your buccal eyes versus the non-buccal eye by a significant amount, right? So could you explain that and maybe tell us why?
Yeah. So there's a number of different theories as to what. So we're not the first ones to show a buccal decreases ocular rigidity. We're the first ones to show it. That happens in living patients. But there have been previous investigators who showed it in cadaver eyes. So there have been a number of different theories as to why that actually happens. And so I think the best explanation is that when you buckle an eye, you're indenting the sclera, and you're actually creating a little channel in the sclera, which corresponds to a decrease in intraocular volume. Right?
Yes.
So when the pressure in the eye then increases, so if you have a non-buckled eye, for the pressure to increase or in the volume, it has to stretch the entire sclera out. And so that's again, that's kind of like your really rigid balloon. It's very difficult to change the volume. And so for any small volume change, like if you were to inject a small amount of fluid in the eye, like if you were to do an intravitreal injection of 50 microliters, if you had a very flexible eye, you're going to have a small ILP change. But if you have a rigid eye, that's going to be a high ILP change. So in a normal eye, it'd have to stretch out the entire sclera, which is difficult. And so that's why you can get a very high ILP change. Now, if you have that buccal that's already indented the eye wall, and you inject that same 50 microliters, it doesn't have to stretch the sclera. All it has to do is stretch the buccal, because the sclera is just returning back to its normal position where it was before you put the buccal on. And so the amount of amount of pressure, the amount of energy that you need to stretch out that buccal as opposed to stretching out the entire sclera is less. And so for that same volume change, you end up with a smaller pressure change.
Okay. Makes sense. So you already have shrunk the volume of the eye by the buccal.
Yep.
So and the argument is that that is more malleable, that can go back to the normal position easier than the whole thing being made of collagen and the sclera. You have more. It's like a spring in the eye. You can go up and down a bit. Okay.
Yep.
It makes sense. I'm just thinking, maybe because all the incisions you make, you also have more of almost empty space, which, you have, as if you have all these tunnels within the scleral wall, they can expand and collapse a little bit. Mind you, over time probably comes less, but that, I don't know, of a non-glaucoma person.
Yeah. And so, it really depends on how you're doing your buccal. Are you doing sutures? Are you doing belt loops? So, there may be a difference there. Our sample clearly wasn't big enough to look at that. But in one of our graphs, we did find that there's this trend towards losing that effect of decreased ocular rigidity over time.
Mm-hmm.
And so,
What would that be? What would that?
Well, so what we think is happening is probably, if you leave that buckle on long enough, and I'm sure you've taken out buckles. If you take it out after many years that's been there, the eye doesn't bounce back right away. There's
No.
you have that little ridge
Yeah.
around the eye.
Yes.
And so I think because of that, you're over time, you're no longer returning the eye to its normal position. You're actually stretching the eye from its new normal position.
Yes. Yes.
And then you can also get fibrosis over the buckle, which probably increases the rigidity.
Mm-hmm.
So
Yeah, it makes sense. So your argument holds here that maybe that spring function is less of a function later on.
Yep. As over time, as it scars and remodels.
Okay, makes sense. So what does this mean that you have decreased rigidity with presence of a buckle? So what does that mean? That means you have less IOP fluctuations in a glaucoma person. How is it practically related to patients?
Exactly. So because the rigidity is lower, there will be smaller IOP fluctuations. Mm-hmm. And we think that it may be the protective mechanism that we see from scleral buckle, where scleral buckle patients just seem to be less prone to developing glaucoma later on. So we're definitely requires more work to validate that. Mm-hmm. But we think that's probably what's happening in these patients. It's just lowering their IOP fluctuations.
Mm-hmm. Okay. So you have two things to show that maybe the protective effect of the buckle. One would be a decrease in ocular rigidity. One would be a less of a change from seated to supine position.
Right.
It may be related to each other, these two phenomena.
They are. So Yep. So it's the decreased ocular rigidity results in the decreased IOP fluctuations, including the sitting to supine change.
Mm-hmm, mm-hmm. And somehow related to your article and results. So you mentioned a little bit that is there sort of documents and studies showing the long-term beneficial effect of buckle in IOP progression in glaucoma patients, or no? It's just more like an observational thing.
Yeah. So no, we don't know that yet. Our past study, we specifically excluded patients who had pre-existing glaucoma. Mm-hmm. There is one paper from the 1970s that showed that patients who had scleral buckle potentially had slower progression of glaucoma, but clearly that needs to be repeated with a larger cohort. So, that is definitely something that we're looking at.
Mm-hmm. Mm-hmm. Okay. And it's good that they don't need as much traps, probably, because so that would make the surgeries hard. It sounds like it's protective anyway.
Yep.
Okay. Wonderful. Anything else, Dr. Sid, you want to add to this discussion? Anything you feel we missed or you want us to remember from your article?
Yeah, so I think we covered a lot, and I think it's pretty comprehensive. I guess the one thing, just not related to this article specifically, but just I think one really important lesson was that it's important to keep an open mind when you're doing research, because we did not expect to go down this path. As I mentioned, we're actually hoping for the opposite result, mm-hmm, that buckles would not be good for glaucoma. Mm-hmm. But that's serendipity, and it's that's how research goes. You find things that are unexpected, and then you can just continue down that path.
Yes, and that's a sign to the purity and objectivity of your research. A good researcher is open to the opposite result, and versus having a very fixed mindset and going for what they want to look for, being flexible and scientific is what matters a lot. And I congratulate you for that and for doing this work and producing all the work you do. And thank you very much for coming to the Retina Channel podcast.
Well, thank you very much. It's a pleasure and a really great chatting with you.
Pleasure was mine.
Well, folks, this wraps up episode 78 of the Retina Channel podcast.
I want to thank Dr. Sid for coming to the show and so kindly teach us about the flow dynamics inside the eye with the presence of a scleral buckle. I personally learned from that a lot. A bit of a heads up about our next episode is going to be a discussion with optometry, the relationship between optometry and retina specialty. That's a chance that I had during Toronto Retina Symposium to have a roundtable with a few of our optometry colleagues and talk about how we can improve the relationship between the fields of optometry and the specialty of retina. Until that episode, I wish you all the best and take care.